I now have the privilege of presenting Professor Christian Sirois, who is a thoracic surgeon from McGill, and he's kindly joined us even with his very, very busy schedule. He just took the plane this morning, just arrived a few minutes ago, and made it just in time, just like every good surgeon. Timing is everything.
Thank you. I would like to say thanks to CNET Canada to invite me for this conference. So I'm going to I have quite a bit of slide, and we are short of time, so I'm going to skip some slide, or I'm going to go fairly fast on some slide because some topics are already been discussed earlier today, and tomorrow also Dr. Granberg was going to talk about the diagnosis of long neuroendocrine tumor. But I always like to discuss a bit about history of carcinoid tumor. You know, so the first carcinoid tumor has been described, in fact, by Théophile René Laennec in Paris in 1930, and later on, Oberndorfer coined the term carcinoid, which is very important because carcinoid looks like a cancer, and it's not exactly a cancer. So we're going to talk about it later on. Gosset and Masson first described this tumor as an endocrine tumor, and Dreamer in 1930 coined the term adenoma of the bronchus. So this is Laennec that described a bronchial carcinoma tumor in 1830. Also Fehrter in 1938 described the neuroendocrine tumor system, which is very important. And also Arrigoni in 1972 described the atypical carcinoid tumor. So carcinoid tumor in the lung are a fairly rare tumor. They usually have a relatively indolent clinical behavior. They have this neuroendocrine differentiation, and what is very important, and you probably all know here in the room, that it's not a benign process, it's a cancer. And why it's important is every patient come in my office with a carcinoid tumor, they all think it's a benign. They tell me, doctor, it's a benign tumor, isn't it? And I have to take half an hour to explain that no, it's not a cancer. And unfortunately, also, many physicians think that it's a benign tumor because the usual clinical behavior is the survival is very high, but those tumors, they can come back. You have to follow those patients for a long time. So, there's also a different synonym for a carcinoid tumor. It could be a neuroendocrine tumor, can be a bronchopulmonary neuroendocrine tumor. We can call that also Kolchitsky cell tumor 1, 2, or 3. So there's different classification I'm going to explain to you later on. And so bronchial carcinoid tumor made out of 1 to 2% of all lung cancer. And for all the carcinoid tumors, 20 to 30% are from the lung, actually. It's a tumor that we see often on teenagers. And the typical carcinoid tumor, we see the average age is around 45 years old. The atypical carcinoid tumor is a bit older. And the incidence, as you can see, vary depending of different feature. But the incidence is actually increasing, and we're not sure why. We think that the pathologists are better to make a diagnosis, but it could be other factors like better scan to pick up those tumors, and maybe there's a true incidence, true increased incidence of the tumor. We're not sure exactly, it's not clear. Smoking, which is related to usual lung cancer, it's not clear if smoking increases the risk of to have a carcinoid tumor. 1/3 to 2/3 of the patients are actually smokers, but it might be irrelevant. The causality has not been proven. We also have seen carcinoid tumor in some multiple endocrine neoplasia, MNN type 1 syndrome, which are rare, and this will be discussed later on. The classification, actually it's a spectrum of neuroendocrine tumor disease, actually. And it's not always a line between each type of cancer. Sometimes there's some variation. You have the typical carcinoid tumor. After that, you have the atypical carcinoid tumor, which are more better prognosis. And after that, you have the large cell neuroendocrine lung cancer, which is very bad prognosis. And finally, the small cell lung cancer, which is extremely poor prognosis. In my talk, I'm going to talk mostly for the two first one, the typical and atypical carcinoid tumor, because they share the same behavior overall. The WHO classification, again, demonstrate the typical atypical carcinoid tumor, and also they add the hyperplasic neuroendocrine cell lesion, which are called tumorlet, actually. Histopathology, we have discussed that earlier today. A typical carcinoid tumor is the mitotic rate is less than 2 per 10 power field. There's no necrosis, and if you have a typical carcinoid tumor, you start to see some necrosis and more mitosis, basically. So I'm going to skip those. You have seen that earlier. Those are slide of histopathology, and this is a picture of a typical carcinoid tumor on gross appearance. The classic staining for carcinoid tumor are the silver staining, and you have also other type of staining study to make a diagnosis. Lymph node metastasis. Even a typical carcinoid tumor, you have between 5 and up to 20%, depending on the series. You can have lymph node metastasis, so it's significant. And atypical carcinoid tumor, the incidence of lymph node metastasis is even higher. So it's very important to take that in account when you treat those patients. There's also some other variant of carcinoid tumor, which are rare. Clinical presentation actually is a classic triad, which is a cough, hemoptysis, and recurrent pneumonia. This is a classic triad for bronchial carcinoid tumor. And sometimes you can see also wheezing and chest pain. Those are the frequent symptoms, but actually the most frequent symptom is no symptom at all. It's like often the patient are asymptomatic, and we found the carcinoid tumor by a simple routine chest X-ray, something like this, or if the patient had an X-ray for an unrelated reason. But cough and hemoptysis and recurrent pneumonia are the three most common symptoms. You see again the frequency of the symptoms here. And occasionally, the diagnosis can be delayed. In fact, it can masquerade other disease like asthma. Often patients are treated with asthma, and at some point you get a bronchoscopy, and we found a bronchial tumor in the airways. You can have the ball valve effect, which is that the tumor in the airways, in the bronchus, that created a valve that when air goes through the lung but doesn't get out. So the lung, in fact, get hyperinflated. As I said, you can have obstructive pneumonitis or pneumonia and some lung abscess. Often the patient are asymptomatic, actually, and rarely with lung carcinoid tumor you have hormonally related symptoms. It's very rare, it's less than 5%. Actually, those are the carcinoid syndrome that we're going to talk later on. You can see here where are located most of the carcinoid tumor in the lung, more on the right side. The right lung actually is bigger. And in 10% of the time, we can find the carcinoid tumor in the main bronchus, in the main airway, either the bronchus or even the trachea. This is a busy slide, but it demonstrates a different series of carcinoid tumor with a different type of location and so on. Carcinoid syndrome, I'm going to go fairly fast because somebody else will discuss that later on very soon. But it's a syndrome that you can see once in a while, but very rare with lung cancer, with lung carcinoid tumor. And again, the different symptom of carcinoid syndrome. And the carcinoid crisis is important to keep that in mind. If you operate a patient with carcinoid tumor and you do a biopsy or surgery, you always want to have octreated medication close by in case the patient can present with a carcinoid crisis. In fact, the patient could even die, so it's very important to keep that in mind. Cushing syndrome is even more rare. It's also found in bronchial carcinoid tumor, and it's related to ectopic production of ACTH. Acromegaly, this is extremely rare. I've never seen it, but it's described. How we make the diagnosis of carcinoid tumor? Well, you can do a chest X-ray, you can do a chest CT scan, and we can do an MRI, and you can do some scans, somatostatin receptor scintigraphy scan, PET scan, and bronchoscopy. This is some sort of algorithm that you don't have to remember all this, but it's a bit kind of busy slide, but show the way we diagnoses the carcinoma tumor and if we do surgery or not. And this is a CT scan demonstrating the carcinoma tumor on the right side. On the chest X-ray, you can see a normality in about 3/4 of the patient. And the CT scan is helpful to determine the localization of the tumor, if there's mediastinal lymphadenopathy, and also to determine if you have some calcification or not, and so on. So again, a CT scan with a long carcinoma tumor. Sometimes you can do a more precise scan, like a thin cut CT scan, an angio CT scan, or a 3D view. MRI is rarely needed, but sometimes we need it if the tumor is near some vessel. PET scan is controversial. The PET scan demonstrates a low-grade uptake on the tumor. Sometimes we don't see any uptake at all, so it's controversial. I like to use it if possible, but I will not delay a surgery for a PET scan if it's too long to get the study. And same thing for a traumatic scan. The sensitivity is good, but the specificity is limited. Bronchoscopy is useful to make a biopsy for central airway bronchial carcinoma tumor. And so you can do a biopsy, and it's very important to have a good setup when you do a biopsy, because those tumors are kind of fairly vascularized, and you can have significant amount of bleeding. But if you're well prepared with a epinephrine solution to prevent too much bleeding, usually there's no problem. The carcinoma tumor bronchoscopy has a classic appearance of, you can see, of a tan color. It's a very classic, and even many physicians think that we don't even need to biopsy since the fact it's so classic, and you just go ahead and resect. Again, there's a busy slide showing the treatment algorithm for a typical and atypical carcinoma tumor. I'm going to pass the slide for giving the time. And so, what are the treatment options? Surgical resection is the best choice if the tumor is localized and minimal extension. You can do another endoscopic resection, but this is controversial. And you have other type of therapy, like adjuvant therapy, either somatostatin, chemotherapy, or radiation therapy, but I'm not going to go into detail. I'm mostly going to talk about surgical resection, which is a treatment of choice. It's said it's the only real chance for cure. The goal is to resect the tumor en bloc in one piece, and you try to avoid going through the tumor if possible. And you want to preserve as much lung function as possible. So basically, you want to remove the tumor, but keep as much lung as possible. Otherwise, the patient will be too short of breath after the operation. You can do a lobectomy to resect a lobe. There's 3 lobes on the right and 2 on the left. You can resect a part of the bronchus, and we call that sleeve. That's you reconnect a bit like a sleeve. And you can do a segmentectomy, which is a part of the lobe. A wedge resection, which is like a pie-shaped type of resection of a piece of a lung. You can do a pneumonectomy, which is removing the whole lung. And a bronchotomy is you cut the bronchus and you remove the tumor and you close the bronchus afterward. When you do surgery for bronchial carcinoma tumor, you need to be very familiar with the anatomy, because you have to resect bronchus sometime and reconnect. So as you can see, the anatomy of the lung, it is different segments, so we have to be very comfortable with the anatomy. And so there's some technical procedure called bronchoplastic technique that you can do to avoid to resect too much lung. Like we don't like to do a pneumonectomy to remove the whole lung, because the patient would be significantly short of breath after the operation. So we can do sleeve resection. And we can accept margin of resection. So that means that we cut the tumor. We can accept to cut the tumor close, about 5 millimeter, as long as there's no submucosal spread. So those are a picture of the type of resection you can do and reconnect with an anastomosis. And for a peripheral tumor in the lung, the best treatment is a formal lobectomy. But if the patient has some lung disease and cannot tolerate a lobectomy, you can do a lesser resection, like a wedge resection or a segmentectomy, which is very important when you resect carcinoma tumor in the lung. You have to remove the lymph node. It's very important. We call that the lymph node dissection. This is a slide for the experience in Toronto, and about what type of surgery can be done and the percentage of each surgery. Lobectomy is the most frequent surgery done for carcinoid tumor. The approach when you do a surgery, usually it's a thoracotomy, conventional thoracotomy, which is a big thoracotomy, or these days we do more like a limited thoracotomy, a smaller one, the size of our hand. You can sometimes do thoracoscopy, but when you do thoracoscopy, your ability to remove the lymph node is diminished, you know, so we do that only for small tumor. And we can do also a hybrid type of approach. It's a bit like the hybrid for the cars. It's like a mini thoracotomy with a thoracoscope. So it's a both approach. So this is a conventional thoracotomy. When you do a thoracoscopy, we use a telescope to enter in the chest, like this. And this is hybrid. It's like a mini thoracotomy with a telescope on the side. Lymphadenectomy, there's different extension of section we can do. We can just do sampling. We call that berry picking lymph node. We take a few lymph nodes, but this usually we don't like this. We can do a complete or modified lymphadenectomy. That means we remove all the lymph nodes we can see. And we can do an extensive or radical lymphadenectomy, but the problem with the radical lymphadenectomy is you have more complication and morbidity, so we don't usually do it unless it's necessary. So basically, the surgeon tries to remove all microscopic disease. And this is some slide about lymph node mapping. You can see it's very complicated, even for surgeon, all the station for the lymph node. There's a number for every station, so it's kind of complex, but as you can see here. So every lymph node is mapped, you know, and with a number, basically. What are the surgical outcomes? They're pretty good, actually. We have very low mortality. Lobectomy is less than 1%, and pneumonectomy is around 2 or 3%, and wedge is even less than 1%. So this is number of mortality. 30 days for lung resection, as you can see, is below 1%. So endobronchial management, it's to resect the tumor by the bronchoscope, through the mouth, actually, without cutting the chest. And so basically, we do that either with a YAG laser or photodynamic therapy or cryotherapy or electrocautery. Those are different techniques to burn the tumor and to resect it. It's controversial. It's not considered truly curative because you just remove the tumor, but you always let a bit of microscopic cell on the wall of the bronchus. The indication of a patient, poor surgical candidate, for instance, patient with heart disease, elderly patient, or if the patient has full metastasis, but you want to stop the bleeding, for instance, so you're going to burn the tumor, or let's just say you want to open up the bronchus temporarily and to operate later on. I've done that for a patient where she was pregnant, she was found to have a carcinoid tumor, so we open up the bronchus, we remove most of the tumor, and we operate on her after the pregnancy, actually. So the prognosis is pretty good. A typical carcinoid tumor at 5 years is 87 to 100%. 10 years is in the range of 80%. And a typical carcinoid tumor is less, but it's still not too bad. So we have to, some series, they have even fairly good survival at 5 years. So we have to be aggressive on those patients. You know, if the lymph nodes are positive or negative, it's influenced the survival, obviously, as you can see on this slide. In summary, LungNet are low-grade malignant tumor. Surgical resection is the first choice of treatment and can be performed with minimal risk. With appropriate therapy, the prognosis is excellent. Thank you.